When we did a baseline in Dharavi in 2011, the prevalence of malnutrition was 18%. That means out of every 100 children, 18 children were malnourished. We intervened for 4 years, and at the end of the period, we were able to bring down malnutrition by 28%. The other area we started working on is with pregnant women to educate them about pregnancy, make sure they attend antenatal clinics, they deliver in hospitals so that they deliver healthy babies. But what we found over a period of time was while women were delivering healthy babies, children were slipping into malnutrition. And that's when we started our first program in malnutrition in 2007. It was in 2011 that we actually took on a very systematic, large malnutrition program across the entire area of Dharavi, which is 300 ICDS Anganwadis. These ICDS Anganwadis are the central government's childcare centers. Today, we continue to only work in the 55 Anganwadis where malnutrition is extremely high. It's still at, we have wasting at about 12%, and we have stunting at about 34, we brought it down to 30. And when we started stunting, it was like close to 45%. When we started working on malnutrition, we actually partnered with UNICEF, and we followed a UNICEF framework. We also partnered with Sion Hospital because we were the community-based organization that were giving a medical nutrition therapy, which is a therapeutic food to severely malnourished children. We worked with ICDS because they are the flagship government program. So as a collaborator, we worked with all these partners, UNICEF, ICDS, as well as SNEHA and the public health system. The process of reducing malnutrition it starts with screening every single child. So we had 18,000 children, and the weight and height of those children used to be taken every month. Children were then graded into severe, moderate, malnourished, as well as normal children. Severe malnourished children had a treatment protocol. In some cases, they had to be referred to the Nutrition Rehabilitation Center for what we call an in-facility treatment, where they had to be in the hospital for 15 days. In some cases, depending on the severity depending on the case of malnutrition, they were followed up at home. So the medical nutrition therapy was delivered at home, and SNEHA frontline workers would then follow up with the mother to make sure that the child consumed the medical nutrition therapy or reached the hospital if the child had any illness. For both moderate and severe malnutrition, SNEHA's frontline workers played a very important role in counseling the mother, because getting children out of malnutrition has a lot to do with changing their feeding practices, there's hygiene practices at home, making sure that there is adequate caregiving for the child. So we did a lot of home counseling with the mother. So for example, if you want a child who's moderately malnourished to eat well, you have to help the mother find low-cost, locally available ingredients and help actually almost, we used to have recipe demonstrations in the community so that mothers could learn how to use locally seasonal, low-cost ingredients to cook for their children. That way, actually, mothers began to learn about caregiving practices for their young ones. And that's the way we were able slowly to get children from severe to moderate and back to normal. In addition to the nutrition, we also had to look at immunization to make sure the children were completely immunized appropriately for their age. So tracking the immunization dates, the dosages, etc. was what we would do. We would follow up with the mother. Simultaneously, we would share that data with the public health system so that they brought enough of immunization vials into the community so that the mothers could make sure the children got immunized. A place like Dharavi, you have people coming from across the country. So they come with very, very different belief systems and cultural practices. And very often there is resistance, maybe to immunization, maybe resistance to breastfeeding, resistance to delivering in a hospital when, home delivery may have been the way that most babies were delivered in their native places. So we had to deal with a lot of myths and misconceptions, which over a period of time, with a lot of counseling, a lot of community-based events, campaigns, group meetings, street plays, we were able to create awareness in Dharavi about what is malnutrition, how malnutrition needs to be addressed, and what a mother needs to do to keep her child healthy. So it's been a long journey. We were able to get good results at the end of 4 years. But in many ways also, it was for us an experiment of how to run a large urban malnutrition program in an urban settlement. And the learnings of Dharavi, as well as the mistakes we made in Dharavi, enabled us then to scale to other parts of Mumbai as well as beyond Mumbai. Our nutrition program that started in Dharavi then expanded to Wadala, Mankur Govandi, Malwani, and then outside of Mumbai in Bhiwandi as well as Kasara district. In Dharavi, the first program we started was the program on prevention of violence against women and children. Now, at that time, we thought that the only thing we needed to do was provide counseling services to survivors of violence. But what we later learned is that unless you go into the community and you create awareness on the issue of gender-based violence and how it's not acceptable for a woman to actually experience violence and she needs to access health services, women don't come forward. And while we started with counseling services, we very soon moved to community mobilization, community engagement, where we went out there in the community and we talked about violence through street plays, street art, campaigns, group meetings, to be able to create a sense of understanding of what violence is. It's not just physical violence, it's emotional violence, it's financial violence, and how women need to then access health services, reach out to counseling centers, reach out to your neighbors for help so that women can then get the help they seek. Today, if you look at the work we're doing, it's a very, very convergent model where on the one hand, we look at prevention, which is creating awareness of the issue of gender and gender-based violence. The second is crisis intervention and counseling. So a woman who experiences violence needs immediate help and she needs counseling services. The third aspect is working with the public system. So we work with the police, we work with District Legal Services Authority, as well as with the hospitals, because these are the places that survivors of violence go to for services. So we work with them to sensitize and train them on protocols, as well as how to handle cases of violence. And the fourth area that we work on is on mental health at the intersection of gender-based violence. So today, when we look at the work of SNEHA on the area of domestic violence, we have what we call a socio-ecologic model, where we work at the individual level, we work at the family level, the community level, and of course at the system level for advocacy to make sure that the systems are able to provide services to the survivors of violence. If a woman experiences a fracture because of violence, she will go to a hospital. If she wants to file for divorce, she has to go to a legal system. So there isn't one body that women can approach. And therefore, what SNEHA does is we provide this one-stop service center where she can get counseling, she can access, she can go to, help her to go to a police station to file an FIR. If she wants to take legal action, we have lawyers that help her to file cases for legal action. We have counseling centers within hospitals. So we have our counselors in Nair Hospital, Sion, as well as we run the 24/7 one-stop center at KEM Hospital, along with the Department of Women and Child Development. Now, the reason we work in hospitals is because the most severe cases of violence reach the gynac departments, the burns, the fractures, the orthopedics, and the psychiatry department. SNEHA has actually trained police across 91 police stations of Mumbai. We did an entire citywide training, and we also worked with 3 other NGOs to form protocols of how violence can be addressed in public places, violence against children, violence, sexual assault in public places. So we worked on the protocols, and we continue to do regular training of police in the areas that we work in. One of our flagship programs actually is the Public System Partnership Program. This is a program that was started by the doctors that founded SNEHA, where they set up a maternity referral system which enables the protocolized and timely referral of high-risk pregnant women from a low-level health facility to a higher-level health facility. Now, let me share an example. Very often you will hear of a woman who delivers a baby in between 2 health facilities, maybe in an ambulance, maybe even in a taxi. One of the challenges is that when women are in labor and there is a complication, they need to be moved from a lower level facility to a higher level facility where they can get appropriate care. Prior to SNEHA, there was no formal referral system. SNEHA, the group of doctors at SNEHA worked with the public health systems and devised an entire referral system. It started with one link in Mumbai, where right from maternity homes to peripheral hospitals to tertiary hospitals, they designed the referral linkages, the hospitals that would be part of the referral linkages, the protocols for referrals, as well as the documentation. What started with just one link in Mumbai today is across 10 cities of Mumbai. When you have a good referral system, the woman can reach the appropriate health facility in the shortest possible time. She can deliver in a hospital, and then her delivery outcomes are that much better, actually saving lives of both mothers and babies. This program also worked with the public system to start antenatal clinics in primary health centers. So the primary health centers were mandated to provide antenatal clinics, but they weren't providing. So we worked with the doctors, with the public health system, and today all the primary health posts provide antenatal care, and every woman has at least 4 antenatal checkups during her period of pregnancy. SNEHA's role has been not only in working with the public system to start antenatal clinics at public hospitals, but we have also worked with the community women to make sure that they are aware and they access the public facilities for antenatal checkups.